Thanks, Aoife. So I'm going to speak about the most common motor cognitive disorder, which is DLB, dementia with Lewy bodies. So just by way of opening, I suppose this is a condition which is hugely under-recognised. It is the second most common cause of dementia in neuropathologically confirmed series, probably responsible for 15 to 20% of cases. Yet, when we look at clinical case series from memory clinics, cognitive clinics and so on, it's only responsible for about 5 to 7% of cases. And why is that the case? And I suppose there's a lot of work ongoing internationally and here nationally as well with the Emerald Lewy project around trying to establish why that is the case and trying to enhance and increase diagnostic rates for this condition. And it's important because it carries a much more aggressive trajectory than Alzheimer's disease and is associated with a much greater caregiver burden and socioeconomic burden at a sort of a personal level. And we know it's, as we say, hugely under-recognised, and that people have typically very long diagnostic odysseys, a bit like the tauopathy group, where there are lengthy delays to diagnosis, and that traverses the age groups, but I think is particularly the case for those who have younger onset DLB, which is a particularly under-studied group. So, as Evelyn mentioned in her talk, we're fortunate to have diagnostic criteria for all of these neurodegenerative diseases, and when there's trainees passing through our clinic, I'm always very keen that they have access to and understand the value of these clinically validated criteria so that you can make a diagnosis based on evidence rather than a gestalt feeling. So in essence, DLB is diagnosed based on the consortium criteria, which were published in 2017. That was the fourth iteration of those, and kind of the core anchor feature is cognitive impairment. But very often these people, when they first present, don't have typical memory difficulties. So they're not amnestic, they don't have rapid forgetting, they don't have episodic memory trouble. What they tend to have is difficulty with attention, so sustaining attention or dividing attention, multitasking, with executive function, like problem solving, and with visuoperceptual skills. And they tend to be very prominent with memory following on. And in tandem with that, there are other core clinical features. And in essence, if you have somebody with this cognitive profile who presents with two of the other core clinical features, then you can be pretty secure that what the person is experiencing is DLB. So those core clinical features are fluctuating cognition, and that's sometimes a challenging kind of concept, and I'm going to speak a little bit about that. Recurrent visual hallucinations that are well formed and detailed. REM sleep behaviour disorder, which can often precede the cognitive decline, sometimes by decades, or one or more spontaneous features of Parkinsonism, such as rest tremor, bradykinesia, or rigidity. But something that I think is really important to convey is that you do not need to have all of these by any means, and that you can have a diagnosis of DLB without being Parkinsonian. You can have a diagnosis of DLB without having visual hallucinations. If there's uncertainty around the clinical features, for example, if somebody has maybe just one of those core clinical features in the context of the cognitive profile, then we can use indicative biomarkers to kind of buttress and support the diagnostic formulation. And they are DAT scan or MIBG scintigraphy, both of which we are lucky to have access to here. They're not widely available, but the DAT scanning is relatively widely available nationally. And the other biomarker that's used, and none of these are like hugely specific or sensitive, but are certainly useful in supporting the diagnosis, is polysomnography to confirm REM sleep without atonia. And then there are a plethora of supportive clinical features, none of which are particularly pathognomonic of DLB, but which again, if established and elicited, can really support your diagnostic formulation because they speak to the complexity of DLB as a kind of a multifaceted neurodegenerative disease, with autonomic features, with sleep disturbance features, and with neuropsychiatric features. So I do think we have these laminated in our clinic. I think it's really important to hark back to the diagnostic criteria. And there is, again, from a sort of a usability perspective, there's a well-tried and tested toolkit which would have been developed in Newcastle around the time I was there, called the Diamond Lewy toolkit. And this is just to make these diagnostic criteria kind of more readily applicable to the real world memory clinic setting, and they're available online. And again, the Emerald Lewy project here in Ireland is really sort of emphasising the use of these toolkits to make day-to-day identification of these symptoms and these features easier. So I'm going to speak a little bit about fluctuating cognition because I think this is a challenging one, and we know from literature on DLB that it is hugely under-recognised. It is a defining characteristic of DLB, and therefore if you can elicit it, it is really quite key and very much points you in the direction of the person having DLB as the cause of their cognitive syndrome. And it's seen in, again, the studies are heterogeneous, but anything between 45 to 90% of people, and it certainly can be present early on. And where it is present early on, it's a very reliable predictor of conversion from that non-amnestic, non-memory-led mild cognitive impairment prodrome into a DLB syndrome, rather than to one of the other neurodegenerative diseases such as Alzheimer's disease. So what is fluctuating cognition? So what it describes is an altered level of alertness and attention with a marked amplitude between the person's best and worst performances. And this is spontaneous and periodic and transient, and it's internally driven. It's not a response to changes in the external environment or milieu. It's not diurnal, such as the kind of typical sundowning that we might see in advanced dementia of all causes. It tends to be more unpredictable and internally driven. And how do people who have cognitive fluctuation or their families describe them? Well, I suppose that's one thing that certainly in those early years, people with DLB, one of the characteristics, they very often have very good insight into their difficulties and will often themselves say that they go through patches or phases where they're not thinking very clearly and patches where they feel really sharp. And the families will often very roundly endorse that if they're asked. But if you don't ask, you probably won't get it volunteered. I remember a couple of years a description being made by a family member which I thought was quite eloquent, was describing fluctuation where it felt like it was a sea fog rolling in and then slowly at some point rolling away again. So clinical identification can be challenging, there's no doubt about that, and there is a very kind of simple checklist which identifies 4 cardinal features of cognitive fluctuation, and if the person has 3 of those, then in clinical practice you can say that they are fluctuating, and that's the presence of excessive daytime sleep greater than 2 hours, periods of disorganised thought or speech, periods of lethargy or drowsiness without the person being necessarily asleep, or staring spells, and that's the Mayo Cognitive Fluctuation Score. And I suppose many of you will be familiar with the story of Robin Williams, who tragically died by suicide, and having had a number of years, I think a short number of years, if memory serves, of a motor cognitive syndrome which was not diagnosed while he was alive. So he had a very prominent neuropsychiatric change in his cognitive well-being and some Parkinsonism with hallucinations. And this is about 10 years ago now, I think, that he died. He wasn't diagnosed with DLB, the diagnosis was made post-mortem. And Susan Schneider-Williams is his widow, and she's been a huge advocate for a greater awareness around the existence of DLB and better diagnostic and management for this condition. And in this article that was published, a very really sort of poignant article published by Neurology, which is one of the leading clinical journals of neurology internationally, she described her experience of Robin's illness. And in there's a very clear description of fluctuation. So she said that typically the plethora of LBD symptoms appear and disappear at random times, even throughout the course of the day. I experienced my brilliant husband being lucid with clear reasoning 1 minute, and then 5 minutes later, blank, lost in confusion. And there's a very clear overlap between these cognitive fluctuations and delirium. And delirium, I suppose, is something that we all see really commonly in the acute hospital setting, particularly in older people. And hypoactive delirium is probably the most profound cognitive fluctuation of all. We know that people with DLB are exquisitely prone to delirium. They can have recurrent bouts of delirium, very prolonged, dramatic delirium, and often with only a very trivial or no clear trigger at all. And in people who have all comers with dementia, so all types of dementia, a prior history of delirium associates with 3 to 5 times the risk of having DLB over Alzheimer's disease. So it's a real red flag for a DLB syndrome brewing. And in that context, the prodromes of DLB are increasingly recognised. 3 particular sort of prodromes years before dementia is overt, one being mild cognitive impairment, one being a psychiatric type onset, and a third being delirium onset DLB. So, sorry, just going to go back here. So, just sort of to illustrate that with a case that we saw as a ward consult, actually, unsurprisingly, a 75-year-old gentleman who was brought into hospital by his family with a 2-week history of fluctuating disorientation, variable level of alertness and responsiveness, some sort of unusual paranoid ideation. He had reduplicative paramnesia, which is something that you don't see too often, but it's a very unusual sort of phenomenon where he felt that the environment where he was had been created elsewhere. He was basically had been quite a high functioning man, but on probing with his family for about 6 to 8 months before this hospital admission, they did acknowledge that he had had some difficulty with his attention span, with executive dysfunction. He had a big sort of grounds and garden where he lived, and he took great pride in managing that, maintaining that. He was really beginning to struggle with that in the year or so prior to this admission, and he'd had 2 unexplained falls. And when we met his wife, she was clear that for a couple of years prior to all of this, that he had had some dream enactment behaviours where he was punching and kicking her in his sleep. So when we first met him, he was, very typically, delirious. He was disoriented. He was perseverative, tangential in his speech. It was difficult to get a handle on whether he was rigid or not. There was a lot of parotonia, and there were some intermittent myoclonic jerks. Myoclonic jerks, I suppose, are something that we see very commonly with DLB, particularly as it advances. But when you see it in a more subacute setting, does invoke other potential causes, such as autoimmune encephalopathy or the spectre of prion disease. So he had a very detailed workup, which was largely unrevealing, other than to say that there was definite evidence of some global atrophy out of proportion for his age on his MRI. So he improved with supportive care. There was no clear infective trigger for this. He was treated early enough for a lower respiratory tract infection. And after about 4 weeks, he was really back to his cognitive baseline. At that stage, his Addenbrooke's score was approaching normal, about 85 over 100, and probably had some very subtle symmetric Parkinsonism. But with follow-up over time, 2 years into the trajectory, cognitive symptoms had accrued. He dropped his cognitive scores. There was a very clear-cut story now of cognitive fluctuation evident and more obvious Parkinsonism with significant dysautonomia in the form of urological symptoms and orthostatic hypotension. So that's a case of, a sort of a delirium-led DLB. And I suppose the mechanisms behind fluctuating cognition remain poorly understood. So when I was in Newcastle, this was something we reviewed, and it's several years ago now. And to be honest, we're probably not much further along in our understanding the kind of mechanistic underpinnings of what drives it. But it is a very fascinating, very singular feature of DLB, and it probably is attributable to alterations in how we control our default mode network, which is sort of the resting state network of the brain being kind of inadvertently switched on or not switched off on time. Those of you from the west of Ireland might recognise this name, who is the incoming president of the University of Galway, and he's a previous very highly published neurologist with an interest in DLB and Parkinson's disease from Newcastle. So how do we manage cognitive fluctuation? So I suppose one of the key things, like any symptom in dementia, is educating the patient, educating the carer. We're very reliant on our nurse practitioner, Emmett, in terms of linking in with families in that respect. And cognitive fluctuation is an odd sort of thing for patients and families to experience, so education is certainly a key component to recognising that. It's important that people understand the importance of routine, of scheduling, particularly scheduling, say, naps and breaks, and trying to avoid cognitive overload and that sort of those things that can trigger a decompensation in respect of kind of cognitive burden, such as multitasking or dividing attention excessively. I'll speak a little bit about pharmacological management more generally in a moment around cholinesterase inhibitors and memantine, and then the value of other pharmacological approaches. For fluctuation specifically, I suppose, remains relatively understudied, but as with any of these cognitive difficulties, you can't underemphasize the importance of linking in with the multidisciplinary team from the perspective of day-to-day function with occupational therapy and the difficulties around speech and communication with SLT. So from the fluctuation perspective, I suppose there's some things that we've observed just in the clinic over the years. One thing I would always say to the trainees: beware the patient who has initially presented with mild cognitive impairment, but where you've been suspicious that they might have a neurodegenerative disease, but you haven't been quite able to sort of prove it maybe, and they come back and their score on the day is better. That what you may be capturing there is a fluctuation. So just to sort of have that in one's mind, if there's still a lingering doubt in your mind or the person or the family's mind that something is happening. Because the person with DLB can often have, paradoxically, a good day when they come into clinic, and this is something we would see quite a bit, where patients informants would say, "Geez, I can't believe he's like this. He's amazing," and we don't really know why. But I guess it is something you encounter, and it's possibly just that their attentional pathways are switched on because of the trip to a new novel environment relative to their home environment, where the fluctuations are often very more evident to the family. A challenge, I suppose, is that fluctuation is something that can be seen in all dementias, but in, say, the likes of Alzheimer's disease, it tends to be in response to the external environment changing or changing routine, whereas it's more internally driven in DLB. And a key aspect of the fluctuation we see in DLB is that poor alertness, the poor level of alertness. So a person with Alzheimer's disease, in the normal course of events, would typically be alert, but somebody with DLB who's fluctuating will not be. The other hazard sometimes that we would encounter, particularly sort of from the neurology perspective, is that not inappropriately sometimes these are treated as seizures because they're altered periods of awareness that come and go. But I suppose there are some clinical differences. Seizures are typically brief, fluctuations can often go on for hours. Seizures are often very stereotyped, and usually people have some sort of positive, as we say, phenomenology in the context of a complex partial seizure. It might be a gaze deviation, eye blinking, mouth or orofacial movements, as opposed to just being completely phased out, so to speak. And the difference being that, I suppose, with a cognitive fluctuation, you can typically rouse the person out of it, whereas with somebody having a complex partial seizure, you can't rouse them, you can't bring them out of it. So from a pharmacological perspective, the options for cognitive enhancement in DLB from the cognitive impairment perspective, really front and centre are the cholinesterase inhibitors. This group of medications will often be described as game changers by patients and families, and you tend to see a better bang for your buck, so to speak, in DLB from the cholinesterase inhibitors than you do from in Alzheimer's disease patients. So typically we use donepezil because it's once daily. In studies comparing with rivastigmine, it's as effective, and compliance is probably better. We sometimes use off-license doses if there's been a good response to the initial license doses. I have used galantamine once or twice, but I haven't found it to be particularly as effective as the other two. Adjunctively, there is an evidence base for memantine for addition to cholinesterase inhibitors, or where cholinesterase inhibitors are contraindicated. And again, we don't have great, evidence base for non-pharmacological interventions, but it speaks to reason that anybody with a cognitive syndrome who has functional impact, particularly, is referred to occupational therapy for, functional assessment and or to their local memory technology resource room where that's available. And similarly, from the communication piece, the importance of targeted speech and language interventions. So, I suppose cognition's the core of, cognitive dysfunction is at the core of DLB, but really there's huge complexity in terms of other features, and I'm just going to kind of touch on a few of those. So sleep disturbance, I'm going to talk about a couple of aspects of that. So some of you will recognise this quotation from Macbeth, which kind of speaks to the restorative value of sleep and to general well-being and health. And sleep is very much affected in DLB, and I'm going to focus on two particular ways. The first being REM sleep behaviour disorder. So this is something which I suppose there are a couple of potential pitfalls. One is underdiagnosis, which is common, as in not identifying it, and the second is maybe overdiagnosis. So from an underdiagnosis perspective, patients and family members, bed partners, they often won't volunteer this, so we do need to ask about it, and we need to kind of I suppose have a sense of what we're looking for. So RBD is dream enactment behaviours. REM sleep tends to accrue, the proportion of REM sleep accrues during the course of the night. So REM sleep behaviour tends to become more evident in the second half of the night. Behaviours that happen in the first half an hour of sleep are almost invariably non-REM, so that's not RBD. So it's a second half of the night phenomenon. The person's asleep, they're in bed, their eyes are closed, they're dreaming, but they're acting out their dreams. So in typical REM sleep, every muscle in our body is paralysed, with the exception of our breathing muscles and our extraocular muscles, which move, hence the name rapid eye movement. That switch off does not work in RBD, and people move through their dreams, and the dream content is often associated with threat, and so often people are kicking, punching, and vocalising very loudly. And often people would say that, the people would shout expletives and so on, and it's very much at odds with their daytime personality. They don't tend to get out of bed. It tends to happen in bed while they're asleep. Up and out of bed, eyes open, that's non-REM parasomnia, which again is common in all types of dementia, but is not as specific as RBD is for DLB. So we don't, I suppose, know, unless we ask, we often won't get that history. And in fact, about 75% of people who have RBD confirmed on the objective measure, which is polysomnography, won't know that they have it. And I suppose a lot of our patients are older, sleep alone, and so on. There is the potential risk then of overdiagnosis of RBD, and for example, iatrogenic contributions, so SSRIs, beta blockers, can create an RBD type mimic, but probably the biggest mimic of all is obstructive sleep apnea, which is really common in the population, as we know, particularly as obesity becomes ever more prevalent. It's about 50% of middle-aged men who are overweight or obese have sleep apnea and don't know it, a lot of them. And this is the great mimic of RBD, but the two can coexist. So really, I suppose, I find that we're not infrequently referring to colleagues for a sleep workup in the respiratory services or the dedicated sleep service in James's if we're unsure. So from a treatment perspective, I suppose RBD doesn't always need to be treated. More often than not, I would say it doesn't, but if there's any injurious behaviour or risk of injurious behaviour, melatonin has a very good evidence base, so does clonazepam, but melatonin is better tolerated. Cholinesterase inhibitors also have a role in this, and for some very refractory cases, oxybate has been used, but that's quite a difficult drug to use, particularly in a cognitively impaired group. So excessive daytime somnolence then is something which I think is, again, probably relatively unique to DLB as a dementia syndrome. You don't tend to see this in the AD group or the FTD group or the tauopathies. If anything, they tend to be troubled more by insomnia. So it's a supportive diagnostic feature. It's very easily identified using an Epworth score. And if you identify that somebody has excessive daytime somnolence, what you need to do next then is explore what their nocturnal sleep quality is like, because there are a lot of things that can fragment sleep and that travel along with DLB that can be treated. And as I often say to people, there's nothing that makes for, bad nights make for bad days, but we can often intervene and make the bad nights a bit better, where we can identify trouble with sleep disordered breathing or restless legs. So these are overrepresented in DLB cohorts. About 90% of people who have restless legs have a correlate in their sleep called PLMS, periodic limb movements in sleep, where they get kind of periodic twitching or jerking sort of a joint, ankle or knee, and it's very kind of predictable to the bed partner. And with each one of those, the person's experiencing a little micro arousal, and it's that's very inimical to kind of their sleep quality and fragments their sleep architecture, leading to daytime somnolence. Notable though, RBD of itself doesn't cause daytime somnolence. Usually the person just sleeps through and gets back to sleep if they do wake up from the dream, but these other features can. All that being said, excessive daytime somnolence of and by itself, independent of other things that might be fragmenting or interfering with the sleep of these people, is a key feature of DLB. Just these people tend to have, sleepy brains, as a sleep neurologist I worked with would refer to. So, restless legs, again, probably in day-to-day practice we under-recognise this. It's very easily diagnosed. There's a very simple kind of clinical criteria centred around 4 clinical questions. And an important thing from a pharmacological perspective is that a lot of these people will have relative iron deficiency, and again there are guidelines on what that means. They often are not profoundly anemic, or may not be anemic at all, but have insufficient iron stores. And in that case, iron supplementation is useful, and indeed IV iron can be very helpful in some of this group, and it's something that I have used in people with DLB in the past to good effect in order to target restless legs. Otherwise, probably the go-to agents are the alpha-2 delta ligands, pregabalin or gabapentin, in low doses at night. So autonomic dysfunction is, I guess, again, one of the most challenging aspects of DLB. Again, not something that you typically see or expect to see in Alzheimer's disease or FTD. And I suppose the 3 kind of pillars of this are neurogenic orthostatic hypotension, constipation, and urogenital symptoms. So the neurogenic orthostatic hypotension is something that's seen very commonly in older people, and I guess where we see that in the context of cognitive symptoms, it's always worth considering that there's a unifying diagnosis which might be DLB. So many of you will be familiar with the sort of conservative measures that are used to try to tackle this. From a pharmacological perspective, there are a number of agents which we would use, most typically midodrine or fludrocortisone. I haven't found pyridostigmine personally to be particularly useful, even though there are some studies that would suggest that it is. And in refractory cases, I have use droxidopa, which is available as an unlicensed medicine and is expensive, requires a bit of monitoring, but can be helpful. Constipation is almost universal in this cohort, as many of you will appreciate. And again, the non-pharmacological measures are really key, but almost invariably we would end up using macrogols, the likes of Movicol and so on, as bulk-forming agents. And in refractory cases, secretagogues. I haven't a great familiarity with that group of agents. I've had 1 or 2 patients where they've been prescribed by gastroenterologists, but not something that I've personally prescribed myself. Urogenital symptoms, on the other hand, are something that we would see almost invariably in this group. It can be really burdensome and problematic. It caused a very significant kind of social morbidity, I think. That story, you hear it so often in the clinic about the person who needs to know exactly where the toilet is when they go anywhere. And really, with good targeted treatments, this is something that can often be managed relatively well. We would often use myrobegerin kind of blindly, but would almost invariably refer to urology for a workup where there are significant urological symptoms. I've had a couple of patients where intravenous Botox has been useful for very troublesome overactivity of the bladder. And another thing that's worth remembering, in particularly the younger onset group of male patients, that erectile dysfunction is really common, not often or rarely probably even asked about, and again can respond to treatment if appropriate. So from an autonomic perspective, this is another actual ward consult. It's a 70-year-old lady who had come in with recurrent syncopal events, with the typical story of that kind of anticipatory symptoms. And when we sort of delved into it, there was a history of visuoperceptual difficulties. She was a driver. She acknowledged that her prowess with parking had deteriorated a bit. She was clipping curbs, and she was less proficient from a perspective of multitasking. She liked to host people for dinner in her house and was really beginning to struggle with that over the couple of years. And this case kind of stood out to me because I remember thinking, it sounds like this could be going down a DLB route. So I asked her had she had episodes where her eyes were played tricks on her, and she gave the most florid answer, as sometimes people will, about, oh yeah, well I see these people, they're dressed like, they're dressed in colourful attire like Mexican people with sombreros. Extraordinary, and people can tell you the most extraordinary things. She'd never shared that with anybody before. So again, it's important about asking, because people won't often volunteer and that they're experiencing visual hallucinations. So she had objective evidence of a neurogenic orthostatic hypotension, so that's a profound drop in blood pressure without a compensatory rise in heart rate, and over longitudinal follow-up, cognitive decline began to progress, and she began to experience evident fluctuation and had an abnormal DAT scan, because she never really had a huge amount of very overt Parkinsonism until just the last couple of years, and again managed symptomatically with donepezil, droxidopa in this case, and now low dose of Sinemet. So just very briefly, I'm not going to overstate the motor bit. You'll be familiar with the concept of Lewy body disease being an umbrella, that there's this group that I'm largely focusing on who present with the cognitive syndrome, who have a diagnosis of DLB, and a group who have pre-existing Parkinson's disease, who develop Parkinson's disease with mild cognitive impairment, or PDD. And it is a sort of a spectrum, and arbitrarily there's a 1-year rule, which was kind of initially proposed in research setting in terms of distinguishing these syndromes, and sort of used clinically nowadays as well. So about one thing that's important to take away from this, I think, is that a lot of these people, like the majority of people will have Parkinsonism, and it'll be evident and obvious, but a good 20 and perhaps 30% of people will not have obvious Parkinsonism. So you do not need to have Parkinsonism to be given a diagnosis of DLB if you satisfy the criteria otherwise. And the tremor can be qualitatively different. It's not that it's often not the classical unilateral pill-rolling tremor that you associate with IPD. It can often be bilateral, symmetric. There can often be a postural or an action component to it. Similarly, the bradykinesian rigidity tends to be more axial, a bit like the tauopathy group that Evelyn spoke about, where there tends to be more postural instability and greater body bradykinesia than limb bradykinesia. And the response to levodopa is there, but it's probably not as impressive as what you see in typical idiopathic Parkinson's disease. In my experience, if you use these levodopa very judiciously, slowly, cautiously, in typically lower doses than what you need in PD, it's well tolerated. But you do need to be conscious of the potential for neuropsychiatric exacerbation. Zonisamide, there is some evidence for the use of zonisamide from a motor perspective. I personally have not found it to be hugely effective or well tolerated, and we don't use dopamine agonists or some of the other agents that are used in PD in this group. What can be very helpful for gait actually in this group are cholinesterase inhibitors. And similarly, again, I can't understate the importance of physiotherapy and exercise interventions in this group, both in terms of symptomatic management, but also a suggestion that there may be something of a disease-modifying effect. So I'm not going to, I suppose the neuropsychiatric symptoms are really a talk unto themselves, and often if these are difficult, we'll refer to our colleagues here in old age psychiatry. Visual hallucinations, of course, being a kind of a cardinal canonical feature, but again, not something that you see in everyone. About 80% of people would experience visual hallucinations. And often they can have a sort of a prodrome or a forerunner where they're less formed or complex. So the person might be having, visual misperceptions, or a kind of a sense of passage or presence, like somebody has just passed by their shoulder or has left the room. And cholinesterase inhibitors are really the gold standard treatment for visual hallucinations. It's not that often that one has to resort to antipsychotic treatment unless they're very distressing, in which case then we're very much going to involve our colleagues in psychiatry. The affective syndrome is something which we see very commonly in DLB, both anxiety and depression. The treatments are probably similar to what's used in the general population. And again, like the other neurodegenerative diseases, there's a greater awareness of apathy as part of the experience of DLB, which can be more difficult to treat. Psychosis is something which, again, people can present with or can develop as part of this disease. In practice, we tend to use a lot of low-dose quetiapine. The evidence base has never really been demonstrated in the big studies, but in day-to-day practice, in low doses, it is often used for troubling psychosis in the first instance. But again, often, if it's refractory, we're reliant on bigger guns in the hands of our colleagues from old age psychiatry. So in terms of future challenges, I think like all of the neurodegenerative diseases, it's about better recognition, and particularly earlier recognition. So prodromal DLB, before the person has really declared themselves with overt functional loss. And something which I think is going to really sort of accelerate our progress in that respect is the use of definitive biomarkers. So we're on the cusp really of having clinical access to a CSF test called it's called a seeding assay. It looks for alpha-synuclein, which is the protein which begins to aggregate abnormally in DLB. And there's a kind of a lab technique called RT-Quick. This is really, an sort of really exciting development. It's already entering research criteria for the diagnosis of Parkinson's disease and DLB. I think is something we'll be seeing more of in clinical use in the very near future. It's been something we're very interested and excited about. And then the whole construct of co-pathology, greater awareness that people with neurodegenerative diseases can have more than one pathology, particularly Alzheimer's disease being so prevalent as people age, what the role will be for anti-amyloid treatment in groups of people who have both, and indeed vice versa for treatments targeting DLB where people might have comorbid AD. So, as I say, I suppose a lot of clinical practice starts with research position papers, and about 5 years ago a position paper was published on the diagnosis of prodromal DLB. There are 3 types: mild cognitive impairment, psychiatric-led, and delirium-led. So this is sort of an interesting space to watch. And here in the clinic in Tallaght, I suppose we kind of take this philosophical approach of embedding research and care. So the people who come to our clinics, will often ask them if they want to participate in some way in research without necessarily changing their clinical care, or from an observational perspective. This was something that we just wrote up last year, looking at people who presented with a psychiatric onset of DLB who went on to meet the diagnostic criteria. So lastly, I suppose, just to kind of highlight how things have kind of moved along, this was published in the New York Times in 1999. Before we had robust clinical diagnostic criteria for DLB. And those of you who might have read Death of a Salesman if you're leaving cert or seen the play will recognise Willie Loman. So a gastroenterologist in Seattle wrote to the New York Times saying, "Willie Loman has Alzheimer's disease. All of the signs, all of the symptoms. I wonder if Arthur Miller knows." And that was in 1999. So 20 years later, with the benefit of the DLB diagnostic criteria, we reread the play and identified that Willie Loman actually had DLB. He had attentional deficits, executive dysfunction, visuoperceptual deficits, dramatic fluctuations in his cognition, and vivid visual hallucinations. So these people are hiding in plain sight.